So, good morning everyone. As Sir rightly pointed out that retinitis, unlike other forms of uveitis, is important to be diagnosed. They are more commonly infectious in nature. So, how do I know I'm dealing with a case of retinitis? There can be some specific scenarios that we come across in a clinical practice. A patient may come to us just with some complaints of blurring and floaters, and on fundus examination, anterior segment examination, we see there's some AC inflammation, few cells flare, RL cells are present. When we're doing a fundus examination, we're seeing that there's some vitritis, and we look in the periphery and we see these areas of retinal whitening, such as this case, which was a case of acute retinal necrosis. Another thing is, so once we have these things, we need to identify at what level is this retinitis. It could be full thickness or involving the inner retinal layers, or it could be outer retinal. Now, the beauty of the retina is such that these blood vessels are present in the nerve fiber layer. So anything that is deeper to the nerve fiber layer, the blood vessels would not be obscured. However, anything that is involving the inner retina, the blood vessels would be obscured. So accordingly, we have this patient, which was a case of syphilitic retinitis. As you can see, there is a white patch at the posterior pole. The areas of the margins are fuzzy, and at two places, at one place you can see the blood vessel properly, whereas at the other area you cannot see the blood vessel. Similarly, this was a case of focal toxoplasma retinitis, in which on OCT you can see involvement of all the retinal layers. Whereas if the outer retina is involved, the blood vessels are intact. You can see them going above the vessel properly. You can trace them from the beginning to the end, and you can see this white patch in the deep retina. Another scenario that can be is that they have significant vitritis. In such cases, we can either see a patch of retinitis at the posterior pole, giving the first image, that would be the headlight and fog appearance, or the posterior pole is relatively normal, but we look in the periphery or we examine the periphery, especially the temporal periphery, and we see this area, white discrete area through the vitritis, as a case of acute retinal necrosis. Sometimes they may present looking similar to cotton wool spots, or such as this case of post-fever retinitis. At this point, I would like to point out they need to be differentiated with normal cotton wool spots that we see. So if you can see the difference between these two images, the cotton wool spots over here are associated with overlying inflammation, some thickening of the retina. There is presence of fluid or cystic change at the macula. There can be associated hyperemia, whereas in this image, you can see the cotton wool spots are well demarcated. There is some amount of hemorrhage, so this was a case of macular BRVO vis-a-vis a case of post-fever retinitis. Then there can be presence of focal retinitis in Behçet's disease. So the right eye of the patient has dense vitritis, but at the posterior pole you can see some amount of retinitis, whereas in the left eye we can see these focal areas of retinitis, and an OCT through this shows a full thickness involvement of the retina. Then diffuse retinitis, such as a case of CMV retinitis. So the difference in these patients is that the posterior pole is commonly involved. It is associated with hemorrhages. Image on the right-hand side is of granular type of CMV, whereas on the left-hand side you can see a predominant frosted branch appearance of CMV retinitis. The third scenario would be presentation at an unexpected age with exudative retinal detachment, or a retinal detachment having very posterior retinal breaks, such as this 8-year-old who presented to us with this image. He was started immediately on antivirals, and on day 7 there was reduction in his exudative retinal detachment. At the same time, you can see clearly the peripheral area of retinal necrosis. We need to differentiate these patients with choroiditis. So because choroiditis is deeper, it is more yellow. So the more deeper we go, the more yellowish the lesion becomes. So we did an OCT through this, and we can see that there is thickening of the choroid at this area. So this was a case of focal choroiditis. But not all whitening is retinitis. There can be other differentials to these patients, such as, for example, on the image on the right is a case of Schwarzma syndrome, and that is myelinated nerve fibers and not a case of retinitis. And on the left, you can see partial retinopathy. Again, there is retinal whitening, but there is no associated inflammation in this case. Again, on the right-hand side, there's fibrosis at the subretinal level, but not a case of retinitis, no inflammation. On the left-hand side, there is old vitreous hemorrhage. We cannot see the vessels underlying it, not a case of retinitis. And this case, for example, you can see some yellowish lesion at the posterior pole. There is presence of an inferior exudative retinal detachment. You see in his left eye, there's a small yellowish lesion at the posterior pole. But if you look closely, there is a gravitational tract present in his left eye. So this was a case of CSC. Not all macular exudation can be a part of retinitis. This was a case of Coates disease. You can see the telangiectatic aneurysms at the posterior pole. So my take-home message is that whenever you see any obvious white areas in the retina, please look for signs of ocular inflammation. It could be just a few KPs, few anterior chamber cells, few RL cells, but do go ahead, give a good slit lamp examination to these patients. You see hazy media or vitritis, do a good peripheral examination. At times you may see areas of peripheral necrosis of the retina, which would indicate it is ARN. And if you see a cotton wool spot appearance, so cotton wool spot associated with macular exudation with disc hyperemia, again, look for signs of inflammation. Patients with malignant hypertension can have similar findings, but there will be no vitreous cells on OCT, no anterior chamber or RL cells. And whenever we have patients who present in an unexpected age group, large posterior breaks, sieve-like breaks, please do go ahead and think of retinitis as a differential before thinking of anything else. Thank you.
Thank you so much. So she has talked about general about retinitis and some causes. Causes we would be going in detail in the subsequent talks. But the most important message which goes out from this is that first of all, see if the eye has some signs of inflammation or not. So if there are some signs of inflammation in form of anterior chamber cells, retrolental cells, vitritis, disc edema, some engorgement of the veins, you feel there is some inflammation in the sign in the eye, then if there is a white area there, very high probability that you are dealing with retinitis. Just an isolated white patch like he showed could be something else also. And very importantly, she has mentioned it, but please remember, if cotton wool spots are there, hard exudates are there, disc edema is there, bilateral, number one, do not say it is post-fever retinitis. Number one, yes, get a blood pressure checked. So that is one mistake I've seen, even I have made it once. So first of all, hypertensive retinopathy becomes the first diagnosis, unless, yes, obviously there is some signs of inflammation also in that eye. So the other things also need to be ruled out. But yes, if there is inflammation, there are white patches, and sometimes the inflammation will be so marked that you may not see the white patch. Then be very careful. Definitely move your gaze towards the temporal retina. If there are white patches there, then it might be retinitis underneath. And rather than just giving steroids blindly, you might first give a thought of adding antivirals first. So you have to be very careful, rule out retinitis for these infective causes. Dr. Vinod, you would like to add something?
Very well highlighted, Nawazish. I think you mentioned it, but I'll just re-emphasize on that. That whenever you have inflammation, remember everything we see would come as vitritis, when we talk about intermediate or posterior uveitis. So commonly what we do is we look at the inferior periphery, it's an intermediate uveitis, look for snow banking and all. That is okay, but remember that till we have ruled out the posterior involvement, we can't label it as intermediate uveitis. So please rule out retinal and choroidal involvement in the form of doing a good peripheral retinal examination, and only once you have ruled out the retinal and choroidal involvement, you can label it as intermediate uveitis. So again, emphasizing the fact that if you have vitritis, please rule out the peripheral retinal involvement.
I'd just like to add that the color of the lesion that Dr. Nawazish was talking about is basically on your clinical examination, or for that matter on investigations which are true color and not on pseudo color, because pseudo colors might be a little bit more yellowish than normal. So the whiter lesions are one which you see clinically on your examination, and they are the ones which are superficial. So she's highlighted all the points. Just keep this in mind.
So these are very important points. Again, I would like to highlight what also has been mentioned. Once you say it is inflammation and you see a patch, it is very important to decide first whether it is choroiditis or it is retinitis, because your line of management, a line of investigations might immediately change. So like everyone has mentioned, the color, whether it is margins are blurred or not. The more deeper the lesion, the less sharper the margins would be. The more superficial the lesion, the more involvement of the surrounding vasculature and the blurring of the retinal vessels would be. The more superficial the lesion, the more vitritis, chances of vitritis would be there, unless it is an immunocompromised patient, say a CMV patient. So all these things would help you decide whether it's actually primarily a retinal involvement and later on going into the choroid, or whether it is a primarily a choroidal involvement later on coming into the retina. If you have any doubt, these days we have a very nice OCT to help you there. If you can get a OCT scan through the lesion, she showed you one scan where you were seeing the choroidal bump with some overlying spillover inflammation just above the retinal pigment epithelium. So that is a primarily choroiditis going into a retinitis. Whereas a primary retinitis would see what appear as the entire retinal layers would become hyperreflective and white, and the choroidal layers would either have shadowing if it is too much white, or you still might have the visibility of the choroidal layers. So that gives you an idea whether it is a chorioretinitis or a retinochoroiditis, in case you're not able to decide just based on your clinical